the questions for today. बिस्मिल्लाहिर्रहमानिर्रहीम। तू है एहराम अनवार बांधे हुए, मैं दरूदों की दस्तार बांधे हुए, काबाए इश्क तू, मैं तेरे चार सू, तू असर में दुआ, तू कुजा मन कुजा. Muzaffar Warsi was a very humble and nice person, and I have lots of respect for him. And he recited excellent naats and hams. So this is one of the things from him. Let's start. So the question was, what are the indications for CBT and what are the core components of cognitive behavior therapy? So this is the answer for that. Indications for CBT, simple, straightforward question: depression, anxiety, panic, phobias, anticipatory anxiety, for teaching and problem solving. Some centers also use CBT for management of psychotic symptoms such as delusions and hallucinations. There is lots of work which is done on CBT in psychosis, and one of the Pakistani psychiatrists, Farooq Naeem Saab, presented a paper 2 years ago, 3 years ago, probably in some conference in Pakistan as well, for CBT in psychosis. He did the workshop probably. So if you have any concerns or problems for CBT psychosis, that is the reference. You can go and seek it. So depression, anxiety, panic, phobias, anticipatory anxiety, and CBT for psychosis. These are definite indications, 5 or 6 of them. Core components of the CBT. So we all know that the CBT works. एक slide पहले भी हमने CBT से related की है, 1 या 2 slides. But further moving forward, core components and characteristics of CBT include 60 to 90 minute session per week, typically for 8 to 12 weeks. So usually the CBT sessions are actually 60-minute session for 12 weeks, plus minus 4. You can go up to 16 as well if needed, and you can reduce it to 8 as well if the patient is relatively feeling better. This is the standard, but of course the standards can be flexible if there is some more complication or some other things come up. Symptoms measures are collected frequently. The treatment is goal-oriented and collaborative. Goal-oriented means you have to specifically address the issues which are related to the disease process, whatever the person is having. And collaborative means the patient is equally participating in the therapy. So the amount of the work that you do, the same amount of the work the patient does as well. So it is always collaborative. It's not unilateral that you are giving one thing and then they are just accepting it. Patient is expected to be an active participant. And if the patient is not actively involved, the CBT usually don't work. Treatment is focused on changing current problematic or maladaptive thoughts or behaviors, and weekly homework assignments is the key. So there are, again, 5, 6 basic components. 1, 60-minute session plus minus 30 minutes. Symptoms measures are collected. There is a treatment goal-oriented and collaborative. Treatment is focused, and weekly homework assignments are part and parcel of the CBT and indications I have mentioned earlier. Then there was another question, the guidance for choice of atypical antipsychotic during pregnancy. Now, this is a very tricky question. It comes in the FCPS part 2 as well. Which antipsychotic medications are safe in pregnancy? And there are lots of discussion and arguments and again, research papers available as well. So ideally speaking, no medication is safe in pregnancy. So ideally, a person who is pregnant should not get any medication. But if you look at the prescriptions given by the gynecologist, they always prescribe the iron pill, they always prescribe the B complexes, some painkillers and relaxants as well. So ideally, no treatment. But again, it depends on so many other factors as well. The most important factor is if a patient is known schizophrenia and she is already taking any antipsychotic. Say my patient is on Abilify 30 milligrams per day, and she comes and tells me that I'm pregnant. So what should I do then? So I will assess the patient again, needs and other areas. How is the psychosis? Will she be able to take care of the child? Is there any risk to the child? Is there any risk to the mother? And all those parameters which we usually do. And then I will see which trimester she is in. Supposedly, and it happens most of the time with me, unfortunately, which is very unfortunate. The patient is taking the pills and then she comes in the 5th week of pregnancy and tells me that she is pregnant and she's taking Abilify 30 milligrams per day. So my response, again, one, it is definitely a shock that, oh, you are pregnant and you are taking Abilify for 5 months during the pregnancy, because we always insist that the compliance should be ensured. Antipsychotics should not be shut down suddenly, even if the patient becomes pregnant. And then there is another situation. The patient is diagnosed case of schizophrenia. She is stable on 6 milligram of risperidone. She gets pregnant. She leaves the medication because the gynecologist or other specialist tells them to do so. And they have a relapse during the pregnancy, which is more devastating, which is more complicated, because once the patient leaves the medication, there is a relapse. And when the psychosis is relapsing in the pregnancy, then you are in a more complex situation, because you have to take care of more things again, which is again very, very complicated. So I always suggest to that people, and most of the time when I am asking them that they should not leave the medication if they are suffering from schizophrenia, the compliance is to be ensured, blah, blah, blah. I always assess and then decide how to proceed further. So this is again the clinical situations which are happening with us. But in this situation, if the patient wants to conceive and comes to you that which antipsychotic is preferred because I want to have a baby and I'm taking antipsychotic, then how you should proceed. Is the patient receiving an atypical antipsychotic? Yes or no? If no, then choose one of the antipsychotics for which most safety data are available, which includes quetiapine, risperidone, and olanzapine. These are the drugs which have most data available. There are other drugs as well where data is available, but in most of the situation when you search for it, they will say that again, the data for risperidone is max because it's the oldest one in the market. So after typical antipsychotics, risperidone was the first atypical antipsychotic. So there are lots of studies available related to its safety and in pregnancy. But of course, not all the studies are in favor of it, but we have to choose. We cannot leave the patient without any drug if the person is suffering from a psychotic disorder. Otherwise, there will be more complications. Then there is a data available for quetiapine and olanzapine as well. However, the FDA keeps all these drugs in the categories where there is a risk to mother and baby as well. So those categories could be variable according to the antipsychotics. It varies, but you have to be careful because you need your patient's safety and the child who is coming into this world, that safety as well. And if you believe that now off the record, I'm telling you this, there are few patients of mine who are on clozapine and they give birth to healthy babies. So it depends how you monitor the whole of the situation. So if the person is already on antipsychotic and she gets pregnant or she conceives, then does the medication have demonstrated efficacy? So if the mother comes to you and she is pregnant and she is taking antipsychotic and her psychosis is settled, all I do is to monitor throughout the time period during the pregnancy. So I will go for these scans. I will definitely go for other parameters, making sure that there are no side effects of the medication and effects on the baby. And I will keep monitoring and keep proceeding further in pregnancy. Monitor for ongoing efficacy and potential need for dosage change. That is most important. So this is the basic guideline to prescribe antipsychotic in a pregnant woman. One, diagnosis. Two, is she on a medication?
यार आप प्लीज अपना माइक ऑन कर लें, आप म्यूट हैं इस वक्त।
ओके, ये म्यूट कैसे हो गया? सो स्लाइड मिस हो गई कि कवर हो गई?
सर मिस हो गई पूरी स्लाइड
वाली मिस हो गई।
Okay, I will restart this slide. Okay, no problem. I will restart from this slide. Sorry about that. So, what are the commonly reported themes of clinical delusions? I divide this question according to DSM, but you can use the ICD-10 or ICD-11, whatever you want to use. Delusions remains the same in both the places, so you don't have to worry about it. Defined by DSM, persecutory, my food is being poisoned. Grandiose, I have the power to heal illnesses. Jealous, which is Othello syndrome as well. My partner is cheating on me. Erotomania, Othello syndrome. A famous pop star gives me signals on the radio that he is in love with me. Somatic, like parasitic infestation. Bizarre, my mother thoughts are being carried on the raindrops that fall on the air conditioner. Misidentification, Capgras, Fergoli, reduplicative paraamnesias, and mirrored self misidentification. These are misidentification delusions. Examples of reduplicative paraamnesias, my present location exists in two places simultaneously. Mirrored self-identification delusions, the reflection in the mirror is of another person, not me. Other delusions, thought insertion, withdrawal, external control, guilt, religious, Cotard delusion, and lyncotropy. Example of Cotard is, I am dead, do not exist, my body is decaying. Lyncotropy, I have transformed into an animal. These are various common themes of delusion. It's a lengthy question as far as the SAQ is concerned, because you have to write the names of all the delusions that you usually see in DSM, and then you have to give examples of each. So it's a lengthy question, but this is one of the questions which came in the exam. Okay.
There's a question.
Sorry, what?
Sir, a question.
Sure, go ahead.
Can you hear?
I can hear
Sir,
you.
एक WhatsApp group में recent between a persecuted delusion and a paranoid delusion. So what is a paranoid delusion?
Okay. Now, basically, paranoid is around the delusions around you. Persecutory delusions include three types of delusions, including, ulta bol gaya. Paranoid delusions include three types of delusions: persecutory, grandiose, and jealous. There are two more delusions into it. So basically, the paranoid delusions include five different kinds of delusions. Persecutory is part of the paranoia. Grandiose is part of the paranoia. Jealous is part of the paranoia. Religious delusions are part of the paranoia. And there is another fifth one. So there are five different kind of delusions which comes under the heading of paranoia. When you write paranoid delusion, it can be any one of them. But when you write specifically persecutory, means somebody is against me, or grandiose, I have powers, or jealous, when my partner is cheating on me, religious, when I am the reincarnation of Solomon, or I am the son of Jesus Christ. These kind of delusions are religious. The fifth one I'm forgetting, I'm sorry, but I will try to cover it some other time. So paranoia includes certain themes in it: persecutory, grandiose, jealous, religious. These are paranoid delusions. When you use word paranoia, it could be any one of them. But when you are specifying it, persecutory, grandiose, jealous, religious, then you are actually subdividing paranoia into specific delusion. Are you clear about it? Got it?
Yes, sir. Yes, sir. Thank
Good.
you.
Cotard and nihilistic. Okay. Cotard delusion is an extreme form when the patient negates his existence. Nihilistic is a milder form, you can say. In nihilistic delusion, person says that I don't have a heart. Something else is beating in my body. I don't have the intestines. They are gone. They are decayed. So nihilistic delusion means negating the existing organ. Cotard delusion is a broader thing. So nihilistic could be part of Cotard as well. Same as I told you about the paranoia, right? So paranoia is a bigger thing, including certain themes, and Cotard is a bigger thing, including nihilistic delusion. A nihilistic delusion is part of the when one organ is missing or malfunctioning, nihilistic, negating, right? So negative. Clear? Okay. अच्छा, मुझे नहीं पता था कि ये क्लिनिकल क्वेश्चन पे मुझे इतनी डिस्क्रिप्शन देनी पड़ेगी. आई थॉट के ये यूजुअली आप क्लिनिकल प्रैक्टिसेस में करते हैं, इसलिए मैं उसको स्किप करने की कोशिश कर रहा था. आई एम सॉरी फॉर, आई अपोलोजाइज फॉर माय मिस्टेक, बट आई विल ट्राई that I will explain the clinical themes more specifically for you people. Okay. Then comes the question. Okay. There was a question that there is a flooded area in northern Punjab and you are sent as one of the person to help the flood victims. What kind of things you would be able to go and assess there? This was the question. So assessing, whenever you are called to assess some natural catastrophe, volcano, फ्लड, पाकिस्तान में फ्लड ज्यादा आते हैं, वॉल्केनोस तो नहीं होते, बट वो जैसे अर्थक्वेक in northern Kashmir when there were so many deaths in 1990, 2009 or 2000 something. So that was a big earthquake, and it was very
2005.
right. So I went there, and Professor Harun Rashid Chaudhary, Lajna Naseeb Kare, he was the prime person who went there, and he sent his team as well. But the basic target was not to see all the patients. The basic target was first to assess one, demographics, socioeconomic status, health status, and other parameters, sources of vulnerability to the people who can be more problematic than less people. So about 60% of the population is resilient. They are shocked, they have stress, they have other symptoms, but then they recover. But as a psychiatrist, I'll be, of course, that I will be able to treat the other people as well who are in the time of stress, but I'll be more interested in people who probably won't rebound back, or they are not resilient. So I will then assess the time of hazard exposure. Pre-flood period, how were the situation? During the flood event, how was the situation? And post-flood period, when we reached there, how was the situation? And then we will try to assess the psychological state of the community, the health effects like anxiety, depression, PTSD, stress reaction, illness, infection, injury, or death. If there is death in the family, of course, I'll be more interested to see the grief and perform the grief work. If there is the house was demolished and the person is resilient and he is very, again, religious in content, so he will definitely bounce back to normalcy, but he will have a short period of stress reaction, or maybe he end up at PTSD. So assessing the situation, you always have to, in any situation, as a psychiatrist, you have to assess the demographics, socioeconomic status, health status, and other parameters related to the demographics. Then I will try to assess the sources of vulnerability in the population which is affected. Then I will assess the again, catastrophic status of the population. During the catastrophic reaction, what actually happened, and then after that, what are the consequences? Once I'll be able to assess all these parameters, then I will focus on the psychiatric morbidity. And psychiatric morbidity, which are usually common, is anxiety, depression, PTSD, and physiological, again, illnesses after the flood thing. It's not, again, problematic to see, it's not unusual to see psychosis worsening in these kind of stresses, or depression worsening. So if the patient, 10% of the population was suffering from psychiatric morbidity, all those 10% of the people, if they are the survivors, they will have increased risk of more problematic psychiatric morbidity like suicide, homicide, aggression, violence, agitation, etc. So as a psychiatrist, I have to assess the whole of the situation. And in exam, you have to address these parameters like this. And if you'll be able to, again, explain these things that the way I'm telling you, you won't lose the marks, right? Okay, next question.
Sir, I have a question.
Sure, go ahead.
Right, so thank you. Sir, in the psychological parameters, are we allowed to write psychological first aid or strategies like that if this question comes?
Yes, so it depends on the question. It depends on the question how you have to respond. Now, if they are asking, you are as a psychiatrist sent to a flooded area, how you will proceed? This is the answer, which I showed you in this slide. But if they ask you that these people in the flooded area, these people are suffering from psychological phenomena, how you will intervene in those situations, so you can go for psychological first aid. I haven't seen that question in the exam. More of the questions were related to the assessment than intervention. So just be careful. Don't start doing the intervention when the question is asked related to the assessment. There are two different things. Assessment includes these things. Intervention includes psychological first aid and other things which you have to do, like counseling, medication, blah, blah, blah. But the question is usually not asked in that way. So be careful. The psychological first aid is a very nice term that students start writing immediately. If the question is about the assessment, you don't have to describe intervention. If the question is related to the intervention, only then describe that. If there will be a question, I will let you know. Okay, now this is you are as a psychiatrist sent to a flooded area. How will you assess the risk management cycle or risk management? Now, all of these things are assessments, not interventions, right? So assessment includes formulations of the strategies and policies, principles, bridging the gap, actions, new initiative for improvements, evaluation, flood risk management, implementation, gap analysis, monitoring, and indicators. All of this cycle is assessment. Existing healthcare system, the gaps in the system, how you want to recommend and suggest few things, how you want to change the system, how you want to improve the system, how you want to improve the quality of life of the people who are there, and how you will proceed further. This is all, again, assessment and intervention, not psychiatric intervention or psychological intervention. In another way, briefly, your task as a psychiatrist, key person, would be to evaluate the existing situation, plan for the future, monitor whatever is happening around, and then you will just keep on moving it. Your goal won't be to, as a psychiatrist, to manage the psychiatric patients. And if the question is about the management, again, go for psychological aid. Set goals, measure goals, and define framework. Usually these questions are related to the community questions and community intervention questions and community assessment questions in the primary care settings. Don't expect them to be a part of the tertiary care centers. एक क्वेश्चन पहले भी था कि you are sent as a psychiatrist in a Tehsil headquarter hospital and you will establish a psychiatric ward there. What are the parameters you will utilize? So this question is related to those kind of things. Okay. Now, okay. So this is again a lengthy question. So the question was, what are the causes of mental retardation and how you will assess it? Again, the question was mental retardation in Pakistan. So the question, as far as I remember, was, what are the causes of mental retardation commonly seen in Pakistan? Commonly seen in Pakistan, and how you want to manage it. So there are various causes of mental retardation, and across the globe they are the same, except if they ask a specific question, like what are the common causes of mental retardation in hilly areas, तो उसमें एक चीज ऐड हो जाती है, iodine deficiency in pregnant women, which can lead to mental retardation. Otherwise, the causes are almost the same. So there are hereditary disorders, preconceptual origin, variable expression, multiple somatic effects, frequently progressive course, inborn error of metabolism like Hurler disease, other single gene abnormalities like neurofibromatosis, chromosomal aberrations like translocations, Fragile X syndrome, early alterations of embryonic development like sporadic events affecting embryogenesis, like medication, trauma, things like that. Then chromosomal changes, including trisomy or Down syndrome. Then perinatal influence syndromes like multiple congenital anomalies, intrauterine infections, other pregnancy related problems, and perinatal morbidities, including impingement on progress of fetus during last 2 trimesters of newborn, neurologic abnormalities, frequently disability, stable or occasional with increased expression. Lambi definition. Fetal malnutrition, other pregnancy related problems, perinatal difficulties, premature babies, hypoxia, central nervous system hemorrhages. Then acquired childhood diseases like encephalitis, meningitis, asphyxia, uh, intoxication, environmental problems like psychological deprivation, perinatal neurosis, psychosis, emotional and behavioral disorders, childhood psychosis, autism. Then there are unknown causes, no definite hereditary, gestational, perinatal, acquired, or environmental issues, or multiple elements are present. And all of these causes, if you look at them, they are divided into certain headings. Hereditary, early alterations of embryonic development, other pregnancy problems and perinatal morbidity, other pregnancy problems, acquired child diseases, environmental problems and behavioral syndromes, and unknown causes. Iron deficiency, cause of mental retardation in pregnant women. There was a big study carried out by Institute of Psychiatry under the leadership of late Professor Malik H. Mubashir. And that study was published at various levels. So this question usually comes from IOP. So वो उसमें वो फिर add हो जाता है. But generally, these are the basic outline headings of causes of mental retardation in any setup, right? Okay, बस कर मियाँ मोहम्मद बख्शा मोड़ करम दा घोड़ा सारी उम्र दुख नहीं मुकदे वर्का रह गया थोड़ा. Psychiatry, unfortunately, and psychiatric patient continue to suffer, unfortunately, because of multiple reasons. Okay, coming back, the definition of normalcy. I think I covered this question earlier as well, but again, so there was another type of question. What is defined normality and mental health model of normality? So whenever we say normalcy, as I mentioned to you earlier, there is a bell-shaped curve and 68.6%, 7% of the people lie on one standard deviation, that is normal. If they go beyond that, the possibility of abnormality is there. But mental health model of normality includes 1, absence of mental illness, 2, realistic self-perception and contact with reality, 3, strong sense of identity and positive self-esteem, 3, autonomy and independence, 4, ability to maintain healthy interpersonal relationship, capacity to love and being loved, ability to cope with stressful situations, and capacity for personal growth and self-actualization. मैं जब ये डेफिनेशन पढ़ रहा था नॉर्मैलिटी की तो मैं ये सोच रहा था कि हम पाकिस्तानियों में कितने परसेंट लोग हैं जो इस पे 100% पूरे उतर आएंगे. And unfortunately, this is a very tricky question. We are always bothered about what other people are doing, but we are not bothered about what we are doing. And this is all related to myself, not to anybody else. Absence of mental illness, realistic self-perception and contact with reality. मैं जो हूँ वो ही हूँ, मैं बदल नहीं सकता. A strong sense of identity and positive self-esteem. अगर मेरा नाक बहुत बड़ा है तो है, but it doesn't make a difference. There are lots of people in the world who have a big nose. Autonomy and independence. I want to do things on my own and I want to help people in that way. Ability to maintain healthy interpersonal relationship. कोई भी मुझसे मिलेगा, मैं उससे खुश इखलाकी से मिलूंगा. ओए कीना है तेरा, I won't be doing things like that. And ability to cope with a stressful situation. Stress is part of the life. We should know how to cope with it. IMM examination is a stressful situation, but you should try to deal with it. And the only way to deal with it is to study, study, and study. And capacity for personal growth and self-actualization. You have to keep moving towards certain goals in your life. अच्छी गाड़ी, अच्छा घर, अच्छा पैसा, अच्छे बच्चे, अच्छी बीवी, हर एक की ख्वाहिश है. Think beyond that. Defining normal. Behavioral measures tend to be normally distributed, bell-shaped curve. If the behavior falls within this bell curve, it's normal. For example, intelligence and short-term memory. Other issues of abnormality are harder to apply to a bell-shaped curve of its statistics, like obesity, like high IQ. These are unfortunately sometimes difficult to explain, right? Like if there is 2 standard deviation and the person is having an IQ of 147, then of course it is different and it's normal, right? 2 standard deviation on positive side, high IQ of 147 is normal, but normal in routine sense. Otherwise, considering the normalcy, it is 2 standard deviation beyond that, so we will consider it abnormal. So sometimes these things are difficult to explain. For exam point of view, again, keep remembering that. Don't give examples which you won't be able to justify in other sense. So these are the, unfortunately, loopholes in the definition. Characteristics of good mental health. Just imagine yourself into it and assess yourself. Feels good about themselves, feels comfortable with other people, able to meet demands of life, express emotions in healthy ways, optimistic, stress management skill, decision-making skills, conflict resolution, always uses I messages, copes, adapts with change, assertive, active listener, and can be part of the team or a group. Active listener. It's very difficult situation. Again, most of the time we stop people from talking, and this is considered to be a very bad thing if you are considered to be a healthy person, mentally healthy person. There is another definition of what are the characteristics of good mental health: wisdom and knowledge, humanity, justice, temperance, transcendence, and courage. Temperance include humility, prudence, forgiveness, and self-regulation. Justice includes teamwork, leadership, fairness. Humanity includes love, kindness, social intelligence. Wisdom and knowledge includes love of learning, perspective, judgment, creativity, curiosity. Courage includes zest, bravery, honesty, perseverance. Transcendence includes appreciation of beauty. This is again very strange और बड़ी sometimes complication हो जाती है. खासतौर पर मैं अपने तौर पे देखूं तो मैं बड़ी दफा फंस चुका हूं इस बात से. So if I appreciate a beautiful girl, you look beautiful and you look gorgeous, people start thinking about my character. So appreciating other people, their beauty is not at all a bad thing. Don't take it in a wrong sense. Spirituality, gratitude, humor, and hope. I have to keep instilling hope to all of my patients, all of my students, and all of the people around me. Okay, ठीक हो जाएगा, सब अच्छा हो जाएगा. इमरान खान का डायलॉग घबराना नहीं, मेरा डायलॉग चोरी होके बदनाम हो गया. I'm sorry to say. But that is a hope. That is a big hope. And we have to instill hope in everybody around us. It's a good thing to inculcate the hopeful again, scenarios, demands, and other things into the public. Okay, leaving politics aside. Cognitive distortion. The question was, what are the cognitive distortions in behavior, cognitive therapy? So cognitive therapy and cognitive distortions. This question was repeated multiple times in multiple situations, and sometimes it is asked in OSCE as well, so it is important. The cognitive distortions are: one, all or none thinking, black and white thinking. If I don't get it 100% right, then I failed. Overgeneralization, I never get things right typically. Mental filters, only seeing what is wrong, ignoring positives, disqualifying the positives. Yes, I did succeed, but it was fluke. Mind reading, he didn't even acknowledge me, so he must think I'm a rubbish. Fortune telling, treating future as if already fact. I'll never be happy. I'll never be happy. Right? These are basic cognitive distortion. ये अगर 6 भी, वैसे और भी हैं, बट अगर आप ये 6 भी याद कर लें तो देर आर enough for the exam. All or none, overgeneralization, mental filters, disqualifying the positive, mind reading, and fortune telling. Cognitive distortions are, again, example, all or nothing. You tend to evaluate things in extremes and force your experience into absolute categories, either ya udhar, R ya par. You can't measure up to your exaggerated expectations and set yourself up for a disappointment. So if you are not 100%, you will fail the IMM? No, you will not. Even if you are 80%, 70%, you will still pass. Doesn't make a difference. कहीं पे भी CPSP में नंबर लिखे हुए नहीं आते कि डॉक्टर नासिर के 100/100 हैं और डॉक्टर नायला के 100/65 हैं. दोनों पास फेल का ही लिखा हुआ आता है. So which is fine. So you just have to pass. Again, according to the themes, the types of the delusion: bizarre, non-bizarre, mood congruent, mood incongruent. These are 4 themes that types I have described. Bizarre delusions, non-bizarre delusions, mood congruent, mood incongruent. Mood congruent delusions are basically mood disorders like guilt feelings, hopelessness, helplessness. These are mood congruent delusions. Mood incongruent delusions, when you are expressing something sad, but your facial expressions are very happy. Death of a father, and you're saying, bas ji, pichle mahine abba ji ki death ho gayi thi na. So that is mood incongruent. Mood incongruent, usually psychosis. Mood congruent, usually mood disorders. Bizarre delusion, usually psychosis. Non-bizarre delusion could be other psychiatric morbidity as well, right? So bizarre delusion, imagine impossible situations, and non-bizarre delusions, imagine possible situations. So I see somebody in the mirror and then I decide about something. Non-bizarre delusions, like Harry Potter stories. If you people have seen the Harry Potter, they are actually very bizarre things seen in Harry Potter. So you are taking a broom and you are flying on it. It's a very strange phenomenon. If you consider that bizarre, yes, Harry Potter was full of psychosis. But if you consider that a little bit a step forward, that is an imagination, fantasy, and again, something which is from your creativity, then you won't think it as a bizarre delusion. So it depends from culture, from methodology, from assessment technique, blah, blah. So that varies. But 4 types of delusion: bizarre, non-bizarre, mood congruent, mood incongruent. Okay, again, coming back, there was another question actually in the exam paper, and there were few types of delusions which were written there, like fixed delusion, partial delusion, impartial delusion, complete delusion, things like that. It was a strange question, and I was myself surprised at how this question was asked. But sometimes you get questions which appear to you very strange in the exam. You have to respond to it. I was not able to attempt that question, honestly speaking, myself. If I would have been a psychiatrist making a paper, I won't put a question like this. What are partial delusions? What are complete delusions? Which are, some people do agree with it. I don't believe in it. So it varies. According to fixity, complete, partial, overvalued ideas and ideas. According to the onset, primary delusions, secondary delusions. Primary delusions, sudden onset, delusional mood, delusional anxiety, foreboding something to happen, delusional perception, and delusional memory. These are primary delusions. And if somebody is having primary delusion, it definitely is schizophrenia. Secondary delusions derived from preceding morbid experiences, for example, depressive mood. Then there are persecutory delusions, delusions of reference, grandiose, and being controlled. So all of this, I won't go into that detail. What is NPI? This was the question written. What is NPI and how you will utilize NPI in managing your patients? Again, a tricky question. NPI means non-pharmacological interventions. NPI, non-pharmacological interventions. And non-pharmacological interventions means psychological and social, spiritual, or religious type of interventions that I would like to introduce into my patients. Often, pharmacotherapy alone is not enough to address the devastating functional consequences of any psychiatric morbidity, and people continue to suffer from social, functional, vocational, and other form of disabilities with poor quality of life. So when we want to improve the quality of life, ideally speaking, as a psychiatrist, with the addition of medication, I have to do certain other interventions like psychological, social, religious, and other forms of interventions. This highlights the critical importance of the use of psychosocial interventions to help further the recovery of the people with any disorders, including schizophrenia. These are called non-pharmacological interventions. Example, psychological, social interventions. और उसके अंदर जो further details हैं वो भी बात कर सकते हैं. Then there was a question, evidence-based psychosocial interventions for schizophrenia. We always focus on antipsychotics and their medication. In IMM exam, this was again the question, NPI for schizophrenia or psychosocial interventions for schizophrenia. It includes, अब ये थोड़ा सा याद करने वाली स्लाइड है and you have to go for it. ये 6 नाम याद कर लो. जहां पे भी NPI की बात आए, OSCE में, क्लिनिकल सिचुएशंस में, एग्जाम में, रिटन क्वेश्चन में, ये 6 लिख दो, पास हो जाओगे. 1. Assertive community treatment. 2. Supported employment. 3. Skills training. Cognitive behavior therapy, family-based therapy, psychosocial interventions for alcohol and substance abuse, and psychosocial interventions for weight management. And some of the examples, population and targeted outcomes are mentioned in front of it. Okay, what is BMI? Now, this was the question, what is BMI? And again, it's very simple, so there is nothing tricky about it. Normal body mass index is 18.5 to 24.9. Now they have reduced it to 23. So now it is between 18 and 23, according to the recent guidelines. Normal BMI, body mass index, is 18 to 23. Anything lower than 18 is underweight. Anything over 23 is overweight. Overweight goes into obesity when the BMI goes from 30 onwards. 30 to 34.9 is obesity, and 35 and more than that is extreme obesity. There are various kinds of organs which are involved in it when we are talking about obesity and other issues. Idiopathic intracranial hypertension, cataracts, coronary heart diseases, pulmonary diseases, non-alcoholic fatty liver, gallbladder diseases, skin diseases, pancreatitis, osteoarthritis, gynecological abnormalities, gout, and phlebitis. These are the complications of high BMI. Now, high BMI is commonly associated with psychotropics. So the question could be linked with it. The person is taking risperidone 5 milligrams per day, and how you will assess the BMI, what are the complications? So the answer remains the same. The normal BMI is 18 to 23. Above than that, it is overweight or obesity, complications associated, I have mentioned to it. And what needs to be done is to make sure that despite taking the antipsychotic, which is very essential for him to treat the psychosis, I will try to control the BMI with NPI, non-pharmacological interventions. That will be the answer. Pass ho jayega. Psychosocial consequences of obesity or increased BMI. One, economical impact of obesity. You are slow, you are lethargic, you are eating more, you have sedentary lifestyle. Prejudice and discrimination. It happens in the mental illness as well. Considered lazy, incompetent, and more often absent due to illnesses. Confronted with more problems at job, applications, etc. मोटे बंदे को देख के बंदा कहता है हाँ ये ठीक नहीं है बहुत ही मोटा है यार. So stigma associated with it, and then things complicating it. Causes of obesity: high caloric intake, sedentary lifestyles, midlife weight gain, hypothyroidism, hereditary, usage of drugs. For us, the last one is more important. All antipsychotic causes increase in BMI, can cause the metabolic syndrome, and can lead to multiple physical complications mentioned earlier. Okay, postpartum psychosis. So the question was, what is postpartum psychosis and how you will treat it? No, that it was not the treatment. Postpartum psychosis and what are the risk factors? So postpartum psychosis develops in 0.1 to 0.2% of the population, mostly females, of course. Marda pregnant nahi ho sakta. So postpartum psychosis is a female disorder, 0.1 to 0.2% in general population. Onset usually in 2 to 3 days after postpartum. 5% chances of suicide and 4% chances of infanticide. 4% is a very, very high number. हर 100 औरतें जिनको पोस्टपार्टम साइकोसिस होता है उनमें से वो अपने 4 औरतें अपने बच्चों को मार देती हैं. That is infanticide. That is basically the tricky way why we should treat it. The risk factors: personal or family history of psychosis, bipolar, schizophrenia, previous history of postpartum psychosis or bipolar episode. Diagnostic formulation of postpartum psychosis includes these parameters. Postpartum psychosis usually occurs in 0.1 to 0.2% of the population, usually 2 to 3 days after pregnancy, delivery, 5% chances of suicide, 4% chances of infanticide. There is a strong family history of psychosis, bipolar or schizophrenia, or there is previous postpartum psychosis or bipolar disorders. These are main problems, but there are certain other risk factors like hormonal shifts, immune activation, sleep deprivation, and primiparity. So the first time, the chances of postpartum psychosis are more. Subsequently, in further down the pregnancy, third, fourth, fifth baby, the chances are reduced. So this was the question. Now there was a question, what is the difference between DSM-5 and ICD-10 or 11? Both the same thing. DSM used mainly in USA. ICD is used internationally, Europe and Indo-Pak. DSM is purely for mental disorders. ICD is larger manual, encompasses all illnesses of disease and disorders. Only chapter 5 is relevant for mental disorder. So ICD-11 or ICD-10 is related to all illnesses. DSM is only psychiatry. DSM issued by single national professional body, American Psychiatric Association. ICD brought out by of international collaboration, produced by Global Health Agency with a constitutional public health situation, which is WHO. DSM primary constituents are US psychiatrists. ICD, there are lots of psychiatrists involved in it from developing country and developed countries as well. It's multilingual, multicultural, and multi-centered ICD. DSM approved by Assembly of APA members. ICD approved by World Health Assembly, comprising of 193 member countries. DSM is copyrighted and generates income for APA. ICD is low cost and available free for internet. Now, इसमें ICD की तारीफें हैं और DSM की बुराई हैं, but generally speaking, these are the differences. Okay, that's it for today. Perfect. I have finished it. Wonderful. Okay, I will stop sharing my screen and there will be any questions, I'll be able to respond. Any question? So there were a few questions asked from me, like one of the question was, what is the difference between delirium and dementia? How you will manage delirium or manage dementia? I will try to cover this. I will try to cover Naila's topic as well. I am still waiting for the, again, notification. If anyone